cardiology field, welcome to the Pediatric Cardiology Fellowship, a premier one-year online program designed to equip you with advanced knowledge in the pediatric cardiology field. Our aim is to provide you with high-quality educational materials and up-to-date pediatric cardiology scientific knowledge delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is high quality, up-to-date, evidence-based, and well-structured. Why travel for training when you can learn from top pediatric cardiology experts online? Our program brings world-class instruction directly to you, no matter where you're located, through case-based discussions, Q&A sessions, virtual workshops, and personalized feedback. You'll receive high-quality education that augment and complement your personal training, all from the comfort of your home or workplace. Our pediatric cardiology program offers a comprehensive fellowship structured into 3 modules, 16 weeks each, with a total of 96 credit hours and in-depth training over 1-year period. Balancing work, life, and professional development can be challenging. Our Pediatric Cardiology Fellowship is designed with your busy schedule in mind. With self-paced learning modules and live virtual sessions, you can advance your skills without disrupting your clinical duties. This program allows you to learn and gain experience at your own pace. From mastering congenital and acquired heart diseases to specialized training in ECG, echocardiography, cardiac imaging including MRI, diagnostic heart cath, electrophysiology and arrhythmia management, mechanical circulatory support, and cardiac critical care. You will develop the essential skills to manage children with various kinds of heart disease at any circumstances and healthcare setting. Upon completion, you'll earn an internationally recognized AACME accredited graduation certificate, helping you enhance your credentials, advance your career, and improve your patient outcomes. Join a growing community of pediatric cardiology professionals who have transformed their careers with this fellowship. Don't miss this opportunity. Take the first step towards mastering the pediatric cardiology specialty and transforming the way you deliver care to your sick children. Visit our program landing page and register to reserve your spot. Limited seats available. Don't miss your chance and register today.
Hello, everyone, and welcome to our Pediatric Cardiology Fellowship workshop and webinar today. It's a very special webinar. As you can see, we have 6 contributors between speakers and moderators and the panelists, and we are here to try to improve our pediatric cardiology patients' outcome and your clinical practice. And we are trying to get 2 birds in 1 stone today. We are not focusing only on 1 topic, but 2. So the first part will be focusing on nutrition, and the second part will be focusing on improvement of brain outcome. So we have Marlene Suez. She is a nutritionist from Jordan. She is going to give you a very nice case-based discussion. And Dr. Abdel Fattah Abu Hiwala, he is a pediatric cardiologist also from Jordan. He's going to give you a very nice integrated care and nutrition practice in pediatric cardiology patient. Then Professor Amira Esmat is going to talk about improvement outcome and focusing on the brain in pediatric cardiology patients. We have 2 great moderators, Professor Hibatullah Al-Jibali from Cairo University and Professor Ashraf Harashish from Washington University. So here is our humble agenda today. After this brief intro, Marlene is going to give you case-based discussion. It will be an interactive discussion. There will be a poll, so please try to vote and try to answer her questions. Then Dr. Abdul Fattah Hawala is going to give about 20-minute presentation in integrated nutrition care for children with congenital heart disease. Then Professor Amira Esmat is going to talk about how to save brain and cognitive function in children with congenital heart disease. Again, there will be a Q&A session by the end of the webinar for 10 minutes. So if you have any questions, please feel free to type it in the Q&A box. So again, Marlene Suez will be our first presenter. She is a consultant clinical dietitian, and she is the president of the Jordanian Society of Parenteral and Enteral Nutrition. Dr. Abdul Fattah Abu Hiwala is a consultant pediatric cardiologist, and Dr. Amira Asmat is a professor of pediatric cardiology at Cairo University. Dr. Ashraf is a professor of pediatrics and pediatric cardiology in George Washington University, Washington, D.C., and Professor Hibatullah Al-Jibali is a professor of pediatrics at Cairo University. Again, we are not here to teach you the basis or the facts, but to help you to do a brainstorming and critical thinking and challenge your patient's care to improve your patient's outcome, because we either think or think. So try not to think and try to keep thinking and try to do a better understanding and improve your clinical practice and try to improve your patient's outcome. With that, I'm going to let Marlene to start her case-based discussion. I'm very sure that it will be very interactive, very thoughtful, and informative.
Thank you, Dr. Amr, for this nice introduction. I'm so happy to be with you tonight as a dietitian, sharing with you, the cardiologist, how to support the cardiology patient with nutrition, which is very important. Tonight, I'm happy to share with you a clinical case, interactive clinical case, so that we interact and know what's the best for the sake of our patients. The case tonight will be an 8-year-old girl is referred to the pediatric cardiology nutritional clinic. The medical history was she was diagnosed with tetralogy of Fallot, surgical repair performed at age of 1 year. A residual moderate pulmonary regurgitation, reduced exercise tolerance, and she has poor appetite for the past year. And she also complains from a frequent respiratory infections. When we took her anthropometrics, her weight was 20 kilograms. As we know, it's only on the 10th percentile on the growth charts. Her height was 126 centimeters, which represent 25th percentile on growth charts. Body mass index for sure, she's 12.6, which is below her age, and she lost 1.5 kilograms over the past 6 months. The dietary history, when we took the history of 24 hours, what she was eating, we knew that she skips breakfast, she eats slowly, and she has early satiety, which is expected. Also, she prefers snacks over meals, and when we calculated her calories, she only takes 1,100 kilocalories per day, which is very low. Also, when we did the physical examination, middle muscles wasting in upper arm was found, fatigue during physical activity, and fortunately, there was no edema. The lab results was her hemoglobin was 11.2, ferritin 12, vitamin D 18, and albumin 3.8 grams per deciliter. So the final assessment, the child was diagnosed with disease-related malnutrition associated with chronic cardiac disease and inadequate nutritional intake. So now I will be sharing with you a few questions. I would like you to interact with us to have the best answer that will support us to help this case. The first question, the child estimated energy requirement is 1,400 up to 1,600 kilocalories per day. Current intake is 1,100 as we knew, and that's why she lost 1.5 kilogram in the past 6 months. What's the most appropriate nutritional goal for her? Maintain current weight until cardiac function improves, B, achieve 100 of estimated requirements only, C, achieve a catch-up growth through intake exceeding estimated needs, D, restrict calories to prevent cardiac stress. Please share me with your answers. Do we have already people answering?
Yes,
Okay.
I think the vast majority, 52%, vote for option C, achieve catch-up growth through intake exceeding estimated needs.
And the correct answer is achieve a catch-up growth through, so the majority answered right. Why? Because replacement of nutrition deficit, additional calories for catch-up growth, and regular reassessment for growth velocity. This is the correct answer. Thank you. The next question is, which finding best indicates disease-related malnutrition according to pediatric nutrition assessment principles? A, height at 25th percentile, albumin 3.8, unintentional weight loss and muscles wasting, normal oxygen saturation.
So again, vast majority also voted for option C, unintentional weight loss and muscle wasting.
Excellent. And this is the correct answer, actually, unintentional weight loss, because weight loss, reduced intake, growth failure, loss of muscles, and fat stores is there. Thank you. Okay, question number 3. Despite intensive dietary counseling, the child achieves only 75 of estimated energy needs for 2 months. What's the most appropriate next intervention? So if she's receiving only 75 of her estimated needs, the best is continue counseling alone. B, begin oral nutritional supplement or enteral nutrition. Start total parenteral nutrition, delay intervention until surgery. What do you think?
Think or think.
Think or think. I'm so happy to see people answering correctly.
Yeah, the vast majority voted for B. I think this is the right answer. 68% said begin ONS and enteral nutrition.
And this is the correct, begin oral nutritional supplement or enteral. We prefer the oral nutritional supplement as the first line. Just in case she's unable to tolerate it, we start enteral because ongoing weight loss is seen, failure to meet her requirement, persistent growth filtering. So oral nutritional supplement support should not be delayed until severe malnutrition develops. So question number 4, which nutritional deficiency is most likely contributing to exercise intolerance in this child? Is it vitamin K deficiency, iron deficiency, folate deficiency, or vitamin A deficiency? And this is very easy. I expect 100% answers.
Yeah, it's very straightforward.
Yeah.
I like this educational symbol, but very informative. Yeah, so
Okay.
iron deficiency.
I'm happy with 91. Yes. Okay, so the correct answer is, I'm sorry. Okay, it's iron deficiency because iron deficiency can impair exercise capacity, neurocognitive performance, growth, and quality of life, even before overt anemia develops. Okay, question number 5. Which parameter best indicates successful nutritional intervention after 3 months? Lower respiratory rate, increased body velocity and body mass for age, increased heart rate, or increased fluid intake?
That's also a very straightforward question. So you're giving CC and the PB, I think.
Yes.
Okay.
I want all of them to succeed.
Very nice. So
Excellent.
98, that's improving.
Yeah, improving. So the correct answer is increased weight, velocity, and body mass for age, because catch-up growth, improved body mass index, improved lean body mass, which is more important than body mass index. We all know that body mass index is not anymore the best indication. So lean body mass is the best. Also, better functional status. Two more questions. Number 6, which factor commonly contributes to malnutrition in older children with congenital heart disease? Is it reduced energy requirements, excessive fat absorption, increased energy expenditure and poor appetite, excessive protein synthesis?
That's
So
a very
what?
straightforward question as well. Okay, and the vast majority voted for C, increased energy expenditure and poor appetite. 86%.
Okay, I'm sorry. Yeah. Increased energy expenditure and poor appetite. Why? Because after repair, many children experience increased metabolic demands, fatigue, reduced appetite, recurrent illnesses. So these factors contribute to chronic nutritional risks. Thank you. And I think this is my last question. Why children with congenital heart disease at increased risk of malnutrition even after surgical repair? The first answer is decreased metabolic demands, permanent inability to absorb nutrient, persistent elevation in energy expenditure and feeding challenges. It's universal fluid restrictions.
Very nice. So I think there is still one more question, question 8, right?
Maybe, yeah.
Okay. And I think all your correct answer are either B or C, so that make our life easier too.
Yeah. Okay. Persistent elevation in energy expenditure and feeding challenges, because residual lesion and chronic inflammation, reduce recurrent infections and reduce appetite may continue to impair growth despite the repair. So the 8, I gave you the answer already. Number 8, the child develops acute illness requiring hospitalization. Oral intake falls to 50% of requirements for 5 days. So she's unable to take orally not more than 50% of her requirement for continuous 5 days. According to pediatric nutritional support principles, what's the best action? Observe for another week to give her time. Start parenteral immediately, parenteral nutrition, consider enteral nutrition support, or stop feeding until recovery. And this is easy also.
So choose between B and C, I think. 50-50. And the vast majority here voted for C, 76% to consider enteral nutritional support.
I think they saw the answer, Doctor. No? Okay, so the answer is consider enteral, not parenteral. For sure, parenteral will be our last option in case we fail to give oral or enteral. The parenteral will be the answer, but not if she can tolerate enteral nutrition. If the GI is functional, enteral nutrition is preferred over parenteral. Early intervention helps to prevent further nutritional deterioration. By this, I finish my case. I hope it was informative for you. And thank you for being with us. And now I'm so happy to introduce a great doctor in Jordan, Dr. Abdel Fattah Abu Khwaile. Dr. Abdel Fattah is MD, FRCP from London, BCCA, consultant, interventional congenital cardiologist, former president of Jordan Cardiac Society. He graduated from Jordan University in 1984, trained at Southampton General Hospital in UK, former director of Queen Alia Heart Institute at King Hussein Medical City. He's interested in grown-up interventional procedure, the first one to introduce Melody and venous pulmonary valve in Jordan. Also, he's ex-chief editor of Royal Medical Services Journal, and he has a lot of publication in cardiac intervention, and he's active presenter at local and international conferences. It's a great pleasure to have you, Doctor, with us, and we're happy to hear your lecture. Thank you.
Thank you, Dr. Marlene, for your nice introduction and your nice talk. You summarized my presentation, Dr. Marlene.
Okay,
And
very
I
good.
would like to thank the WICCM for inviting me to talk about a very important topic. And my thanks for all, especially Professor Amr and Dr. Marlene and all my friends as well. And I have no disclosure for my presentation, and these are the topics included. I will summarize the congenital heart disease, the importance of nutritional status for patients with congenital heart disease, risk factors of nutritional status for patients with congenital heart disease, estimation of nutrient requirements, and route of feeding, both intervention or operational nutritional care, and lastly, I will give you take-home messages. As you know, congenital heart disease is the most congenital anomaly affecting the human being. And it's about 1 in 25 of the birth, and it varies. It's about 1% of all newborn. So it is very important to look after before and after management and diagnose it. Mostly the defect is developed during the first 8 weeks of gestation. And in majority cases, we don't know the cause. And it is mainly, as you know, it's a multifactorial inheritance. So we have a genetic predisposition and we have a trigger from the environment to promote the maldevelopment of the cardiovascular system. And classically, we classify them into two types, the cyanotic and acyanotic, but this is more precise classification. Type A, left to right shunt, right to left shunt type B, and obstructive lesions. And these are examples. As you see here, the left to right shunt, it is the most common is the VSZ, ASZ, BDA. Initially, they got an increased blood flow, and there is no cyanosis. And by time, they develop pulmonary hypertension and high RV pressure. And at the end, they might develop Eisenmenger, and they got a reverse shunt. What I'm saying, in fact, is the treatment for the congenital heart disease should be treated at the right time with the right procedure and the surgical or interventional, very important. If I close a VSD at the age of 6 months or 4 months, the patient will be in normal. But if I close it at the age of 10 years, maybe I will not be able to close it. They will develop Eisenmenger. This is the importance of management of congenital heart disease. The right to left shunt, it has a better physiology of decreasing pulmonary blood flow and they develop cyanosis. And these are the 5 examples for the cyanotic heart disease: the tetralogy of Fallot, a great vessel transposition, truncus arteriosus, tricuspid atresia, and anomalous pulmonary venous drainage. The obstructive flow or the obstructive or abnormal obstruction in the pathway of the vessels, we see it common. And the most important is the coarctation of aorta, valvular stenosis, aortic or pulmonary stenosis, and in case of complete obstruction, it's called atresia. And these are examples here, as you see here. This is a VSZ here. We have many types of VSZ. It starts by left to right shunt. And in this case, we have an ASZ. And this is a PDA connecting the descending aorta to the left pulmonary artery origin. And this is a common AV canal. We see it in Down syndrome. And this is a large VSZ causing reverse shunt, which I had explained. This is a typical bluish discoloration of the face of the baby presented with cyanosis, and it is usually apparent if we have a deoxyhemoglobin at least 5 grams per deciliter and the SATs below 85. So the importance of taking, in fact, after birth, we should have preductal and postductal autosat for all babies. And in certain countries, it is by law, we have to do it. And the classical is that the trilogy of fellow presented by Dr. Marlene, a nice presentation, and it is the most common cyanotic heart disease in children. And these are the four categories initially. This is the pulmonary stenosis. It has many levels: subvalvular, valvular, or supravalvular. We have an override of aorta. We have VSD and the right ventricular hypertrophy. All these cases at the moment are treated surgically at proper time. The TGA, transposition grade vessels, is the most common anomaly at birth, heart disease at birth. And as you see the specimen here showing that this is an RV, and this is the aorta arising from the RV, and this is the LV, in which the pulmonary is arising from the LV. We have many varieties, but this is the classical one, and it is still the most common cyanotic heart at birth. Regarding the nutritional status, most infants with congenital heart disease have normal weights at birth, and they develop malnutrition and regarding and growth problems later on. The prevalence of malnutrition in patients with congenital heart disease ranges very high, but up to 60%. So the importance of nutrition, we should focus on to treat these patients, and later on we should have a good outcome. Early repair decreases the probability of undernutrition, but still we do have 50%, they come to us with malnutrition and protein energy malnutrition at the time of the intervention. Infants with moderate or severe congenital heart disease are at risk of nutritional deficiency problems, and it is usually associated with increased important morbidity and mortality. So we should focus on nutritional status on our patient. In addition, a poor nutritional status in preoperative time is associated with unfavorable post-operative outcome, increasing the risk of nosocomial infection and poor wound healing. Consequently, early diagnosis and focusing and adequate pre- and post-operative intervention, post-operative intervention are essential in this context. They are classifying into the congenital heart disease into a low-risk nutritional group or high-risk nutritional group, and we have an intermediate, and these are the typical low-risk international group, which is BDA, ASD, pulmonary stenosis, chorioatriatum, unobstructed total anomalous pulmonary venous return. They have a low international nutritional risk for regarding the malnutrition. The high nutrition risk, which are they are very complex issues in congenital heart disease, a pulmonary atresia, tetralogy of fellow, severe lesion, transposition of great vessels, VSD with moderate to severe pulmonary hypertension, and AVSD, hypoplastic left heart syndrome, truncus arteriosus, tricuspid atresia with Epstein anomaly, and double outlet right ventricle. These are very complex congenital heart disease. They are at risk of nutritional deficiency, high risk of nutritional deficiency. Factors associated with congenital heart disease that carry a high nutritional risk, why they develop a nutritional deficiencies. A right or left heart pressure high or volume overload, myocardial dysfunction, patient with congestive heart failure, either primary due to myocarditis or genetic cardiomyopathy, or post-operative with residual lesion, chronic hypoxemia, which is very important, and the associated pulmonary hypertension. Initially, they have increased pulmonary flow, then they develop pulmonary hypertension, and generally speaking, cyanotic heart disease or congenital heart disease with pulmonary hypertension are associated with greater growth delays. So two factors, cyanosis and pulmonary hypertension. We have also extracardiac, as Dr. Marlene explained in one of the questions, factors associated with malnutrition, malabsorption, specific nutrients deficiencies, syndromic patients. We have about a group of patients that develop like trisomy 21 or 18, they have congenital heart disease. Associated extracardiac anomalies. We know every patient with congenital heart disease, they are at risk of 20% to get extracardiac anomaly, intrauterine growth restriction, and preterm babies. We don't like to have a complex congenital heart disease in a baby who is born prematurely. Recurrent respiratory infections, the GERD and gastroesophageal reflux, inadequate energy intake, increased energy expenditure, and some of them though vomits most of the food, and they got fatigue during feeding. It's very important. We call it interrupted feed. The patient or the baby he couldn't continue his feeding. He stops, then he resume back his feeding. This is called interrupted feeding. What basics diagnostic tests from nutritional status we should take after diagnosing a patient with congenital heart disease? Kidney and liver function tests, iron panels, vitamin B12, vitamin D, electrolytes, albumin and pre-albumin. In certain labs, we have pre-albumin which has a shorter time, and it reflects the production of the albumin in the body in short term. And we should always check the thyroid function as well for this patient to explain the malnutrition or growth failure. Regarding how we should estimate the nutrients for these patients. As we said, we classify them into high risk, intermediate risk, and low risk. The low nutrition recommendation for patient should be estimated, and it should be normal. And an intake, these are the figures here recommended regarding the low risk group, about 100 kilocalorie and 1.5 gram per kg for this group. The intermediate is higher, they need higher calories and higher protein. And the high risk group, they need more calories and more protein to improve their nutritional status. Route of feeding. Efforts, as Dr. Marlene said, efforts should be made to maintain a breastfeeding initially for our new infants. And when possible, conventional infant or high caloric formula should be used. And generally, regarding the fluid intake, we shouldn't exceed about 160 ml per kg per day, and we should limit the sodium intake for our patient regarding the management to maintain the good balance in the body. And there is no sufficient evidence to support the recommendation of routine using probiotics in our patients. The oral route is recommended and is the route of choice for all these patients. Restricting the use of nasogastric tube for patients who got difficulty in oral feeding, or they have severe hemodynamic abnormalities which causes fatigue and respiratory distress or triggering hypoxia. So sometimes we give, especially in the preoperative area, a nasogastric feed. If the patient couldn't tolerate bolus feeding, sometimes we use infusion or continuous feeding by gravity feeding tube. Parenteral nutrition is indicated when it is impossible to use gastrointestinal tract for supplementation of the enteral nutrition, or if it is not possible to achieve the necessary intake, especially if the patient got a complex congenital heart disease. We should maintain our policy as well after intervention or surgery. And patients with history of undernutrition, they should continue to have a nutritional support as before the surgery or intervention, and should be followed up by a nutritionist and the nutritional team as well during the intervention, after the intervention, as well as before the intervention. After surgery, history of undernutrition, they require a good support, and it's very important. Enteral feeding should be started as soon as considered safe based on patient's condition. You know, after surgery, they have a pain, respiratory problem, and they are weak, and we should start oral feeding as soon as they are fit to get the oral intake. As we said, we should continue the same policy to maintain good nutrition after the intervention or surgery. And we have certain cases that are complicated by chylothorax, like a Fontan surgery or a Glenn surgery, and they require a special, in fact, a plan of management, nutrition, including the medium chain triglyceride to promote the fat metabolism and normal achievement of these factors. How do we assess our patient, either pre or during or post intervention? Usually, we use the standard WHO growth guidelines, the growth charts, and the guidelines of American Society of Parenteral Nutrition, SPN, or the European Society of Pediatric and Neonatal Intensive Care, SPNIC. But the basic and the simple is the use of international growth standards for weight, length, height, head circumference, arm circumference, triceps, and subscapular skin fold thickness, and the calculation of body mass index. All the factors are important, and it gives us a good assessment regarding the feeding status of our patients. And this is my take-home messages for all of you. Congenital heart is the most common congenital anomaly affecting a human being. Malnutrition is a frequent and clinically relevant comorbidity in children with congenital heart disease, contributing to increased morbidity and hospitalization and poorer outcome. The pathophysiology of malnutrition and congenital heart disease is multifactorial, and they have increased metabolic demands, they have reduced oral intake, and they got fatigue, tachypnea, and impaired nutrients absorption as well, contributing to their growth failure. Successful nutritional management requires a dynamic multidisciplinary approach, including the cardiologist, the cardiac surgeon, the nutritionist, and the nurses as well. They are very important, and family, and how to educate the family for proper nutrition. Thank you for your listening to me, and I'm ready to answer any question.
Thank you so much. This was really great. What a wonderful presentation, Dr. Abdel Fattah. We have a couple of questions already in the inbox. Dr. Amr, did you want to speak? I'm sorry, I saw you unmuting.
Dr. Heba is going to introduce Professor Amira and acknowledge Professor Abdel Fattah.
Thank you, Professor Abdel Fattah, for this excellent and fruitful
welcome.
presentation. And now I'm going to introduce Professor Amira Asmat, Professor of Pediatric Cardiology, Cairo University. She is one of the eminent congenital cardiology interventionists. She is the head of the Pediatric Postoperative CCU at the Main Children's Hospital, Cairo University. She is my mentor through my journey. She had a lot of publication and a lot of research in the field of pediatric congenital heart disease. And now we are going to listen to her fruitful presentation about how to save the brain in patients with congenital heart disease and their congenital dysfunction. I think it's an interesting topic
It's my pleasure
to
to
know
share
how
in
to.
this WICCEM webinar and share you my thoughts about cognitive brain function and brain development in congenital heart disease, titled How to Save Brain and Cognitive Function in Congenital Heart Disease. Being pediatric cardiologists, our goal with each patient with congenital heart disease is to standardize his future life, not only his heart status, but also his psychosocial aspect and mental status, trying to ease his adult life. As we all know, the increased risk of neurodevelopmental impairment in children with congenital heart disease has been established. However, the search for targeted neurological predictors of adverse outcome is still going. Starting from 2017, I had the interest for the relation between the oxygen saturation and the neurodevelopmental and cognitive outcome in children with congenital heart disease. This interest became so obvious when I have been the director of the cardiac surgical ICU in Abu Rish Children's Hospital for the outcome of cardiopulmonary bypass and surgically corrected congenital heart disease. I want to raise the flag sign for care of brain while handling congenital heart disease. Topics of our talk today will go through physiology of cerebral oxygen supply and development, pathology of hypoxia in neonate children and adult brains, critical oxygen saturation threshold for protection, neurophysiological assessment tools in congenital heart disease, outcomes across congenital heart disease lesions, effect of cardiopulmonary bypass on the brain, protocols for brain protection, pre, intra, and post-operative, role of anti-epileptic drugs in cyanotic congenital heart disease, and finally, structured neurodevelopmental follow-up protocols. Although brain volume represents only 2% of the body weight, it's responsible for 20% of the total body oxygen consumption. Cerebral oxygen delivery equals cerebral blood flow times arterial oxygen content. The brain functions are subdivided into motor function, language, executive, sensory function, memory, and regulations. The oxygen electrical activity is affected definitely by the critical hypoxemia. So it triggers sequential EEG changes. We have stage 1, EEG slowing. We have stage 2, burst suppression pattern, which is a red flag. Then we have stage 3, isoelectric silence and flat EEG. Physiology of cerebral oxygen supply and development. We have to think about the fetal circulation, the cerebral autoregulation, and the critical growth window. For the fetal circulation, we all know the fetal circulation and that the brain is receiving the highest oxygen saturation in the body, ranging between 65 to 70% in utero. There is higher cerebral blood flow per gram in tissues more than the adults to compensate for the low arterial oxygen tension. For the cerebral autoregulation, neonatal autoregulation is often immature and dependent on the mean arterial pressure. So there is always a risk of ischemia during hypotension or hemorrhage during hypertension. For growing brain and reaching the third trimester peaks, congenital heart disease disruption during this phase lead to brain maturity lag equivalent to 35 weeks of gestation. So patients with congenital heart disease already having immature brain when they are full term. There is different pathology pathways of hypoxia impact in the neonatal brain. There is excitotoxicity and ionic imbalance. There is impaired neurogenesis. There is oxidative stress and apoptosis, and there is white matter vulnerability. It's striking that we have a range between 20 to 50% of cases with congenital heart disease to have preoperative brain injury before the operation. The complex congenital heart disease in neonates prior to surgery shows that there is altered fetal hemodynamics and innate developmental vulnerability, which means that they have already some brain damage before the surgery. This is attributed to the parenchymal and vascular injury, and also they have developmental and connectivity with reduced brain volumes and microstructural alterations with functional disconnectivity. 30% of neurodevelopmental risk in congenital heart disease is attributed to genetic factors operating independently of hemodynamics severity or surgical complexity. All of us know that we have the Di-George disease, the trisomy, the Noonan's, Turner, and Williams, with subsequent neurocognitive impact and primary cardiac lesions. So universal genetic evaluation is recommended for all patients with complex congenital heart disease, especially those exhibiting developmental delays or extracardiac anomalies. With high prevalence of failure to thrive in congenital heart disease, there is impairment in brain growth as well as irreversible deficits in brain less than 2 years associated with iron deficiency anemia. Passing through chronic hypoxemia in children and adults, we came to the target of our talk knowing that there's great neuropsychological impact affecting executive function, cognitive profile, psychosocial morbidity, and motor coordination. Chronic hypoxemia states correlates with accelerated age-related cognitive decline in adults with congenital heart disease rather than other population. Critical oxygen saturation threshold for protection. For the arterial oxygen saturation, we have the figure of 85. So below 85, the threshold increased the neurodevelopmental risks. And for the cerebral saturation that we're going to talk after a while about the NEARS, the safe zone is that more than 65%, which is the optimal. And we have the cut value 65%. And if we go below 50, then we have might have severe deficit, as well as the hemoglobin affections. Below 7 grams per deciliter, there is critical affection of the brain functions. Now we move to the neurophysiological assessment tools in congenital heart disease. We have the standard EEG, we have the amplitude integrated EEG, we have the NEARS, we have the transcranial Doppler. And for their application, the standard EEG is for congenital heart disease in neonates post-op, and for the amplitude integrated EEG, it's to detect real-time seizures and background assessment. And for the near-infrared spectroscopy, we check for cerebral saturation. We have to maintain the cerebral saturation more than 65, which is the critical threshold. And for the transcranial Doppler, we can use it during a cardiopulmonary bypass to check for microemboli. Association between neurological outcome and NEARS utilization has been proved in many publications, whether pre-op, predictor, or intra-op. The cerebral oximetry using the NEARS is a non-invasive monitoring technique based on detection of hemoglobin oxygenation using near-infrared light. We have many parameters like the cerebral oxygen saturation or cerebral tissue oxygenation index or fractional tissue oxygen extraction. If we go and check example 4 calculations, the cerebral oximetry over the pressure index, COPI more than 0.3 indicates disturbed autoregulation. NEARS was helpful for preoperative oxygen brain saturation for stage 1 palliation and was associated with cognitive scores in reported by Hanson et al. Intraoperative also and retrospective studies in patients with biventricular congenital heart disease without aortic arch obstruction found correlation of intraoperative oxygen saturation, brain oxygen saturation, with immediately post-op surgery psychomotor development index, but not with mental developmental index. The majority of studies evaluating NEARS suggest an association between cerebral oxygenation measurements and pre-specified neurological outcome, either clinical or associated with neuroimaging with brain MRI. Assessment of frank seizures or subtle seizures using the conventional EEG or the amplitude integrated EEG was linked to cerebral adverse outcome in many publications. For the laboratory brain biomarkers, we have two types of biomarkers, the one with S100B and GFAP, S100 calcium binding protein B and glial fibrillary acidic protein. They did not have enough proof that they are working or we can count on them for the neurodevelopmental outcome. But a lot of research about the postoperative increase in lactate was associated with neurodevelopmental affection, especially if the level maintained during the first 24 hours more than 4 to 6 millimole per liter with short-term adverse outcome. Now we'll move quickly over the neurological impact of different congenital heart lesions. If we go for neurological impact of left to right shunts, we'll have hemodynamic pathophysiology like the pulmonary overcirculation and the systemic underperfusion with cerebral steal, which is abnormal flow distribution mimicking coronary steal, potentially compromising brain metabolism despite normal oxygen saturation. And for the paradoxical embolism and platelets, hypersensitivity and vascular remodeling, those factors carries the risk for strokes and sensory risks. And for the cognitive trajectory, we have the IQ deficit 10 almost 5 to 10 points below the age-matched control. We have the domain specificity, and we have the post-repair status. For the cognitive outcomes in large left to right shunts, we have the neurological risk profile beyond perfusion, hemodynamic shifts alter vascular and biochemical homeostasis. We have, as I mentioned in the last slide, we have 5 to 10 points average below normal matched controls. We have attention deficit, we have language delay, we have persistence. And while cognitive outcomes are generally less severe than in cyanotic heart disease, the cumulative effect of early cerebral underperfusion necessitates early development screening and monitoring for subtle processing speed delays in school age. For the neurological impact of right to left shunts, we have the paradoxical embolism and stroke, we have the infectious brain abscess, we have the chronic systemic hypoxemia with sustained arterial oxygen saturation between 70 to 85%, triggering compensatory polythysemia. And this polythysemia paradox, which is attributed to elevated hemoglobin compensating for low oxygen saturation, significantly increased blood viscosity, exacerbating ischemia risk. We have also migraine mechanisms, that there is a strong association with right to left shunt due to paradoxical transit of serotonin and other vasoactive substances that normally undergo pulmonary metabolism. The neurodevelopmental trajectories in tetralogy of Fallot, pre-repair pathophysiology for the chronic hypoxemia with saturation between 70 to 85 and the acute cyanotic spills with saturation 30 to 40, and we have the brain vulnerability. And for this, the preservation key is earlier repair, which is associated with improved long-term neurodevelopmental trajectories. And for the long-term neurocognitive profile, we have for the general intelligence, and typically their IQ ranges from 88 to 95, significantly below population, despite technically normal range. We have executive function and attention, and we have processing speed. So patients with tetralogy of Fallot are having impacts on academic achievement in math and reading. Although 40% of pre-surgical cases with DTGA are having problems with hemodynamic instability and structural anomalies with retrograde aortic arch perfusion and circle of Willis variants in 30%. Their long-term neurocognitive function looks perfect with typically near normal IQ mean 95 to 85, yet masks domain-specific weaknesses. And academic struggle in reading and math often intensify as cognitive demands increase with age. When we shift to the univentricular repair, the neurodevelopment and the cognitive functions are worse. For the Fontan, the total cavo-pulmonary connection, the venous hypertension, the reduced cardiac output affecting the cerebral perfusion, resulting in more alteration in neurocognitive profile. The 30 to 50% have ADHD, and 30 to 40% have preschool delay, and 15% of patients are below IQ normal. Now we come to the worst case scenario in congenital heart disease. Hypoplastic left heart syndrome presents the highest neurodevelopmental risk of all congenital heart disease lesions due to combined prenatal hemodynamic alterations, complex multi-stage surgical palliation, and inherent genetic vulnerability. To summarize the outcomes across the congenital heart disease, we have the best one in the IQ with the TGA post-arterial switch operation. We have the worst case scenario is the hypoplastic left heart syndrome, and we have tetralogy of Fallot to have moderate risk, which is a little bit better than the Fontan and Glenn, and we have the VSD, especially if large ones with mild reduction in IQ 90 to 95. But if we look to the whole other brain functions, we'll find that nearly a big percentage of them are having brain function dysfunction, some having global delay like the hypoplastic left heart syndrome, and others are having gross motor delay or social maturity and ADHD prevalence like the TGA. So the brain is really affected in most of the congenital heart disease. A major risk for affection of the brain development and cognitive function is the cardiopulmonary bypass. The cardiopulmonary bypass can affect the brain in different ways. It can trigger systemic inflammation source. It can cause hemodynamic instability. It can trigger microembolization. The thermal and metabolic stresses where the patient is exposed are very high. The hemodilution and oxygen delivery is affected during cardiopulmonary bypass, especially if the hemoglobin drops and there is massive bleeding, if the hemoglobin drops below 7 to 8 grams per deciliter, and there is disruption of the blood-brain barrier through the cytokines released from the cardiopulmonary bypass. All these factors leads to the fact that 25 to 80% of patients are having frequency of neurocognitive impairment at the time of hospital discharge following cardiopulmonary surgery. The neurocognitive impairment, which is counted for 25 to 80% at discharge, did not disappear after discharge. There is still a long-term persistence of neurocognitive affection. From 30 to 50% of the cases that had the cardiopulmonary bypass, they show still neurocognitive dysfunction. Affecting the cognitive domains with attention and concentration, processing speed, executive function, and memory. And for the thermal management dynamics, the hypothermia protection reduced cerebral metabolic rate. Rapid rewarming carries the risk that's causing cerebral hyperemia. So the predictors of decline, if intraoperative EEG showing burst suppression and epileptiform discharge, or there is postoperative delirium and glycemic dysregulation, or there is hematocrit dilution, hemodilution below 25%. So there's reduced oxygen carrying capacity. Now we move to the preoperative brain preservation protocols. The neuroprotective window begins in utero. Newborns with complex congenital heart disease exhibit a 3 to 5 weeks lag in brain maturity, as I mentioned before, necessitating immediate metabolic and hemodynamic stabilization. If we think about the prenatal optimization for early fetal diagnosis and screening and maternal stability, avoidance of maternal hypoxia and hypotension, and for the coordinated delivery planned in a special cardiac center, we target to reduce the time to intervention to preserve cerebral electrical access. And for the metabolic control, we have to optimize the hemoglobin, glucose and pH, and the surgical timing. Avoidance of metabolic derangement is critical for synaptogenesis. And for the baseline assessment, we have the preoperative NIRS, and we have the structural MRI, and we have the neuroconsultation that should start as early as possible. Characterizing pre-existing injury is vital for postoperative prognosis. EEG monitoring during cardiopulmonary bypass can be a real tool for protection of the brain and evaluation of the brain during cardiopulmonary bypass. The physiologic EEG evolution, we have the baseline, we have the induction, we have the hypothermia, and we have the rewarming. And the asymmetry warning, lateralized EEG patterns or asymmetric voltage during cardiopulmonary rewarming suggest focal cerebral ischemia or embolic events. The high-risk predictors is the presence of the burst suppression, the epileptiform discharge, and if we use the amplitude integrated EEG, it provides simplified continuous bedside monitoring in NICU and PICU to assess the background activity and detect seizure in real time. To continue neuroprotection during cardiopulmonary bypass, we have to utilize the cerebral monitoring using the NIRS. We have to adjust the hematocrit and the pH state strategy. We have to have a metabolic control, glucose management, and serous mitigation. We have the temperature and to control rewarming and to control rewarming and to avoid hyperthermia. We have the perfusion strategy, and we have the anesthesia on neuroprotection, burst suppression or dexmedetomidine use. For the postoperative brain preservation and management, we have to concentrate on hemodynamic optimization, advanced neuro monitoring, and neuroprotection and environment. We have to attain the cerebral perfusion pressure, and we have to maintain the oxygen delivery. We have to control a glycemic state. And for the advancing neuro monitoring, we can have the continuous EEG, the conventional EEG, and we have the nurse guided management, and we can check early seizure for intervention. And for the neuroprotection and environment, we have to avoid the hyperthermia and to developmentally support the care, minimizing the environmental stress and noise and light and cluster care, and we can have early referral pathways. I told myself once, if there is subtle electrical activity that can affect brain cognitive function, why not to use anti-epileptic drugs? Then the debate is the benefit versus the risk. What I found here, I found that the use of anti-epileptic drugs as a metabolic stabilizers, it prevents the cumulative synaptic injury from silent ictal events. The benefits is that the seizure prevention, neuroprotection, and preserved IQ trajectory. But the risk is that drug interaction, potential neurotoxicity of older anti-epileptic drugs. The levetiracetam is ideal for pediatric brain development and with clinical consensus that it's a recommended first choice anti-epileptic drug for congenital heart disease patient due to its superior safety and neurocognitive profile. Now we shift to the structured neurodevelopment follow-up protocols. We have a long-term surveillance schedule for the neonates, the infancy, and for early childhood, for the preschool entry, and for the adolescence and transition. We have to have the ASQ3, which is an age and stage questionnaire. Screening is recommended at every cardiology clinic visit from birth to 5 years to ensure early identification of emerging delays. And we have to contribute to the multidisciplinary team with the cardiologist, the neuropsychologist, the neurologist, and the pediatrician, the social workers, and the orthostatic, and the physiotherapist, and all the multidisciplinary teams should be around the patient all the time and all the visits to make sure that we are going on the right way. And for the intervention pillars, we have the family education and empowerment, we have the early intervention and referrals, and we have the school support. So take home message that always we have to consider brain development and cognitive function every time we deal with congenital heart disease, especially those with univentricular cyanotic heart disease. Now we reach the end of this complex topic in congenital heart disease. I want to thank you all for your time and attention.
Thank you so much for this nice presentation. Thank you, Dr. Abdel Fattah, and thank you, Marlene, for great presentations before. We will have our questions and answers section, but I want to reflect. As you guys saw, these presentations were discussing neurodevelopmental outcomes after congenital heart disease surgeries or, after we take care of those patients. We discussed also the nutrition. I just want to reflect and say congratulations to our community that we're no longer talking about mortality with congenital heart disease. Dr. Abdel Fattah, I'm sure, had seen patients who did not do well and unfortunately had died throughout in the early phases of cardiology. Nowadays, we're focusing on their clinical outcome and their chances of achievements and succeeding in life. There are a couple of questions in the Q&A. So the first one I'm going to ask Marlene to answer. And the question is, you already have mentioned it, but let me ask it again. If a patient is having gastric edema or continuing to have vomiting, what's our options for feeding?
Okay, if there is vomiting, we usually prefer enteral but post-bilevic. Okay, so we might consider the NJ really directly to the jejunal. And in case he's not tolerating, we might move to, if continuously vomiting and he's not tolerating the NJ, we can move to parenteral nutrition.
Thank you so much. Dr. Abdel Fattah, I will paraphrase a question that was raised. So if you have a child with a large VSD, now is, let's say, 9-month-old, and the child is also having failure to thrive and a nutrition problem, what's your priorities at this moment? Are you calling Marlene to get a nutritional support, or are you calling the surgeon to close it, or are you taking the kid to the cath lab to close that VSD? What's your number one item that you will concentrate on?
Thank you for your question and audience question as well. This is very important topic, and as you know, VSD is the most common cardiac lesion. We are facing it daily. So our practice first is to improve the nutrition, and the guidelines nowadays is at least we should have a good nutritional support in the last 10 days prior to intervention or surgery. Okay? Second, we should treat patient with anti-failure to stabilize the hemodynamics. And third, we go to close the main pathophysiology of this defect, which is the VSD. So it depends on the site and the size of the VSD. If it is small and away nowadays from the aortic valve, we close it by transcatheter. And if it is large, we go for surgery. Unfortunately, still there is a good place for surgery in VSDs. We started transcatheter closure for perimembranous VSD in 1997. And unfortunately, later we have something called late heart block by transcatheter. And this has shifted the management towards more surgical for perimembranous VSD. Just I would like to say about the VSDs. We should diagnose the VSD first. We should treat first, nutritional support, then to go for a for closure at proper time.
Excellent. Thank you so much. We appreciate you. And Dr. Amira, with regard to the neurodevelopmental evaluation, I love the last slides that you included about how it is so important for us to be screening those children. My question to you is, how often do your colleagues send you patients that they're having problem with language or with fine motor skills? Who do you refer them once you identify these problems?
Actually, I started to think about this issue maybe a while ago. Then what I started to do, I started to do the patient's IQ. I have many MD theses to check for the patients, because the point is that sometimes we have a lot of absence from school. So you cannot evaluate whether this patient is just skipping the school because he's ill or because he's not interested that much. At that time, we sent them to the neuropsychiatrist, but till now, we did not have a real protocol for this multidisciplinary part of the system. Actually, I don't know whether in the States they're keeping more attention to this issue or no.
Thank you. So we do have the cardio neurodevelopmental outcome team. It's a PhD neurologist at our center who is running that program. CANDO is multi-center collaboration as well that focuses on the neurodevelopmental outcome. And, I do the board review series for George Washington University, and I want to give my colleagues an advice that it is so important for you to really appreciate the talks that we're given today. In PrEP 2024, for example, there are questions about the importance of nutrition in patients with hypoplastic left heart syndrome, for example. These topics that you hear today are very, very important, and you will see that they will appear on your boards, whether it is for this course or for any other board that we deal with. Marlene, there's a question. I'm not sure if you want to take that one or Dr. Abdel Fattah. The question is, when you have someone who has failure to thrive, what's the weight at which you are going to assess how much calories they need? Is it the current weight that they are admitted with, or do you calculate what their ideal weight should be and do your numbers based on that? You are muted.
Okay, I think we should consider the 50 percentile weight, and we should work on it. But I don't know, Dr. Abdel Fattah, if you have another opinion.
In fact, we were going for the ideal weight.
Yeah.
So we calculate more calories.
Yes.
For this patient. So they get good nutritional status pre and during and post operation.
Okay. Dr. Abdel Fattah, you have many you're becoming so popular in this webinar. I sent you the message that one of your patients had sent, 32-year-old lady, and I'm not really sure what Almas's message is, so maybe the team can forward that message to you as well.
Thank you.
Sure. Thank you guys so much. I'm going to end this and now invite Dr. Amr to end our presentation for the day.
Thank you so much, Professor Ashraf, for moderating the discussion. Thank you, Marlene. Thank you, Dr. Abdel Fattah, Professor Heba Al-Jibali, and of course, Professor Amira Ismail. Very informative and thoughtful discussion and great presentations today. We all learned. For all of our attendees, you should all receive certificate of attendance by next week, and you should also receive the YouTube link of this recorded webinar by tomorrow. And the door is still open. If you are interested to join our 1-year online pediatric cardiology fellowship, you can apply. You already have the registration and the application link in the chat box. With that, we are going to close this session, and stay tuned for our next month webinar. We'll have more and more high quality educational webinars in the next couple months. Have a good rest of your day, good afternoon, good evening, and good night,
Yeah.
wherever you are.
Thank you very much. Thank you.
Thank you.
Bye.
Thank you very much.
Thank you.
See you soon, inshallah.
Thank you.
Inshallah.